This podcast is not CME eligible. If people do want to learn more about CME eligible podcasts, Alex, what do they do?
They can go to GeriPal.org/CME.
And on to the show. Welcome to the GeriPal podcast. This is Eric Widera.
This is Alex Smith.
And Alex, I love this episode. We're going to be talking about all things Alzheimer's, amyloid, and antibodies today. Who are our guests who are going to be talking about this?
We have all returning guests today. This is terrific. We're delighted to welcome back Heather Whitson, who's a geriatrician and researcher at Duke, and she is co-director of the Duke UNC Alzheimer's Disease Research Center. Heather, welcome back to the GeriPal podcast.
Thank you. I'm glad I made it back.
And we're delighted to welcome Halima Amjad, who is a geriatrician researcher and dementia specialist at Johns Hopkins. Halima, welcome back to the GeriPal podcast.
Excited to chat today.
And Barak Gaster, who joined us pre-COVID when we were an audio-only podcast back in the day. Barak is a primary care clinician and dementia expert at the University of Washington and director of the Cognition and Primary Care Program. Barak, welcome back to the GeriPal podcast.
Happy to be here.
Can I just say how awesome it is? We have 3 dementia experts, 2 of them geriatricians, 1 of them primary care. I just want to highlight how cool that is. But before we get into this topic, Heather, I think you have a song request for Alex.
Yes, I'm going to request my favorite song, Harmony Hall, normally sung by Vampire Weekend, but today sung by Alex.
And why this song?
So I figured we would probably be talking about blood-based biomarkers, so Vampire was part of the inspiration. But also, it's my favorite song right now.
It is a great song. I had not heard this song, but I had so much fun. I went to town, so those of you who are listening to the audio-only version of this, you're going to get my version with many instruments. It was a lot of fun. So thank you so much for this request, Heather. Here's a little bit. We took a vow in summertime, now we find ourselves in late December. And I believe that New Year's Eve will be the perfect time for the great surrender. But they don't remember. Anger wants a voice, voices want to sing. Singers harmonize till they can't hear anything. I thought that I was free from all that questioning. But every time a problem ends, another one begins. And the stone walls of Harmony Halls bear witness. Anybody with a worried mind could never forget the sight of wicked snakes inside a place you thought was dignified. I don't want to live like this, but I don't want to die.
Lovely. Thank you, Alex.
That was great.
How do you do, Heather?
That's a jam. Love that one. Thank you.
Love it. You did it. You did it proud. Thank you, Alex.
All right, I'm going to start at the top. And again, we're going to have links to past episodes that we've done on amyloid antibodies, thinking about how to diagnose somebody in primary care with Alzheimer's disease. But you don't have to listen to that. We're going to actually start from the very top. I'm just thinking, Barak, you do a lot of teaching of primary care providers, right? On how to diagnose dementia, how to think about Alzheimer's disease. There's a lot of competing definitions out there right now. What is Alzheimer's disease? From, the more traditional, like it requires both clinical and a pathological diagnosis versus just it's all biomarkers. How do you talk about Alzheimer's disease to the primary care providers that you see?
Yeah, and we're still in such an area of flux where everybody's still trying to figure out what do all these words mean. And I really sort of, in terms of what we sort of the training we do for primary care doctors and as part of the Cognition Primary Care Program, really focusing sort of absolutely at the center first is identifying somebody who has cognitive impairment. Like that is the sort of most important giant first step, making a diagnosis of either mild cognitive impairment or dementia in the primary care space. And then after that, there is the question of, what might be the etiology of somebody's cognitive impairment. And, we are really sort of, make it clear that it is often difficult to make a precise diagnosis, that most people have mixed forms of dementia, and that we really encourage primary care to use the A word, because that is the word that sort of patients and families know. And if Alzheimer's, and if they walk out of the exam room only hearing mild cognitive impairment, they may be thinking like, phew, thank God I don't have Alzheimer's. People have never, most people haven't heard the term mild cognitive impairment. And so we do encourage use of the word Alzheimer's and how much uncertainty there often can be in identifying that as an etiology for somebody's cognitive impairment.
Can I ask, because there's more and more push to say Alzheimer's is both, again, clinical and pathological. So actually knowing there's amyloid in the brain on top of just having MCI or mild dementia versus saying somebody has Alzheimer's but not really knowing if there's amyloid in the brain. How do you think about that?
Yeah. So, I mean, I acknowledge that there's just a lot of uncertainty about it, and that somebody can have Alzheimer's and have a negative biomarker blood test, like that. I mean, it doesn't have 100% sensitivity for Alzheimer's disease. And so I really do think that it is important for us to stay grounded in the clinical syndrome of MCI dementia and the clinical syndrome of Alzheimer's disease, with the overlay that, we are gaining sort of better understanding of, possibly being able to identify the presence of amyloid plaque in the brain, somebody with cognitive impairment, which is a more robust diagnosis of Alzheimer's disease.
Now, Heather and Halima, you work in specialty dementia clinics. How do you think about defining Alzheimer's disease? How should we talk about it, when we're talking to primary care providers or with patients? I'll start off with you, Heather.
So, I feel like we're in such a moment in this disease that the field is moving so quickly that I usually start by just acknowledging that there's not agreement amongst the experts in the field, acknowledging that there are schools of thought that don't agree that Alzheimer's disease should ever be diagnosed without clinical symptoms. And there are others who feel really strongly that if we're going to get to a point, especially if we're going to talk about risk reduction for people who don't yet have devastating cognitive changes, that moving to a purely biopathological understanding of Alzheimer's disease is the right thing. And so I kind of start by acknowledging that we're at such a fast moving point in this field, making so much sort of disruptive progress, if you will, that there are experts, card carrying bona fide experts that don't agree on that point. And I just think we have to sort of acknowledge that. Personally, I'll sort of put my cards on the table. I fall in the school of thought that I'm okay with calling it Alzheimer's disease without symptoms. I'm okay with...
If somebody has amyloid in the brain, that is Alzheimer's disease.
So for me, it's not just having amyloid in the brain, but it's having amyloid in the brain and the pattern that is consistent with Alzheimer's disease. The problem is our current biomarkers or tools can't always tell us with that level of granularity. But if we could know that the person had amyloid in the brain that was because of the Alzheimer's disease pathology, I'm okay. I think that there's value in calling that Alzheimer's disease. So preclinical Alzheimer's disease exists in my world.
Yeah.
But I also acknowledge that the problem with the fact that right now we don't have full agreement on that is that if I tell a person that they have Alzheimer's disease and then they go tell their friends and families that they have Alzheimer's disease, and then maybe their insurer catches wind that they have Alzheimer's disease, or their employer catches wind, and they don't understand.
Or they just Google what Alzheimer's disease is. It's Alzheimer's disease is you read it everywhere. It's a dementia. It's cognitive, it's progressive disease. It makes it seem like if you have amyloid, you are absolutely going to develop, you're not absolutely going to develop Alzheimer's disease. By definition, you already have Alzheimer's.
You have Alzheimer's disease. And that's what I mean. If you Google it, depending on maybe your search engine, and how the functionalities work. And you might land on a page that tells you it means one thing, and you might land on a page that tells you it means something else right now.
Halima, where do you fall?
So I appreciated hearing that comment about there's not agreement, because I was going to say I actually fall into the, whether it's in my clinic or when I'm talking to primary care providers about this topic, saying that, yes, we're at a super exciting time. When I was a fellow, we did not have these, right? Just within the last 2 years, we've started using these tools for more specifically diagnosing Alzheimer's. But to me, the basics haven't changed. And that's that idea of the clinical syndrome, that unless you have mild cognitive impairment or meet sort of all cross criteria for dementia, I'm not necessarily comfortable doing the testing. So ordering biomarkers, going down that path, I can see that perspective of, right, from that research perspective, calling it preclinical Alzheimer's disease, but I don't think we're there in the clinical realm yet. And publicly knowing the weight that that word carries, right? That someone's like, I feel totally fine, and now someone is telling me I have Alzheimer's. So I think we're moving that way, but I am still in that, unless you have objective evidence of cognitive impairment, we're not necessarily going to go down that path yet.
So I want to just completely agree with Halima, and our clinical practices don't differ on this at all. So when I'm in my clinical world practicing clinical medicine, I don't order biomarkers on cognitively unimpaired people. And so because I don't order the biomarkers, I wouldn't make the diagnosis in a cognitively unimpaired person. But I do a lot of research in risk reduction. And so I believe that the leading edge for research is many things are pointing to the notion that the earlier in the disease process that we detect and treat the brain changes of Alzheimer's, that in my mind will ultimately lead to cognitive problems. Now, a person may live out their normal lifespan without that happening. So in those people, they lived out their entire normal lifespan with what I would call Alzheimer's disease, without symptoms. But that's in a research context. So I completely agree with you that in a clinic, but for me, it's just a changing of the framework in which I think about the diagnosis, because I think what we all know too is the elephant in the room is that everything changes if a treatment becomes available that is found to be effective and safe for people without symptoms, but with certain biomarkers. And we're not there right now. We're not
the primary care perspective that I take is like thinking about this in a way like diabetes. Like we have used this term pre-diabetes for so long with kind of a fuzzy concept of what does that mean? And how do we treat pre-diabetes? And does that mean that you are sort of destined to develop diabetes? And, it's no, it's really complicated from a sort of a primary care perspective. And so for me, I really am sort of I encourage primary care doctors to sort of be humble in our understanding of do we really understand the pathophysiology of Alzheimer's disease? And so in some ways, I think the term pre-Alzheimer's is a better term than preclinical Alzheimer's in a way, because I think that from a perspective of primary care, that makes more sense of, lots of people live with pre-diabetes that, for decades and decades and never developed diabetes. And, and so to me, I sort of come back on there's a lot about the pathophysiology of Alzheimer's that we still don't understand.
Okay, so I got a question. So it sounds like you're all in agreement that we shouldn't be using biomarkers to screen individuals who are cognitively unimpaired. Does that I see everybody shaking their head?
Correct. Yes.
In fact, as a person who practices in a memory specialist clinic, please don't screen them. don't
order the biomarkers.
Terrible idea. Terrible idea.
Don't order it and then refer to your friendly neighborhood specialist. Please don't.
And the direct to consumer marketing for that is so harmful and not good.
Oh yeah, health fairs everywhere. People, horrible. It's
happening.
It's happening.
It's happening. Yeah.
Are you guys getting it in your specialty clinics? People coming in with
oh yes
an amyloid test but are cognitively normal?
Yes, and extremely worried. And we're sort of. I mean, I was sort of making light of it a minute ago, but really, honestly, I feel so badly for people who, because they're getting the test most often because they have a family history.
Yeah.
So they've witnessed the toll of dementia, and it's their biggest fear. And they're cognitively unimpaired, well, oftentimes very focused on health and trying to be healthful anyway. They get a test, and my problem when they come in is there's nothing that I would tell them to do differently, knowing this information, than what we would be telling them without the information. But
If
now
they're
I'm
positive or negative, eat healthy, exercise, control blood pressure, risk reduction.
Don't be cavalier about sleep. Yep. all that stuff.
Yeah, I was going to say, we're not seeing it a ton, but I've had a couple of people where, the child of a patient reached out to me because I actually sort of got their primary care provider to send a test. And guess what? It was in that indeterminate range of the, FDA-approved LumaPulse test, or someone who was still uncertain because she had that, again, thinking about the FDA-approved test, p-tau 181 was positive, but it's got terrible positive predictive value. Negative PET scan, but still needed that additional reassurance that your amyloid PET was negative. And so it was hard to say, like, you should have never had that test in the first place. You are cognitively unimpaired. And now she had the amyloid PET. She had to come see a specialist and kind of go down that whole path.
What do you tell, Heather, like the patient who comes in positive, complete, like they are the asymptomatic, however you define it, like stage 2 or pre, also, like what do you tell them?
So what I tell them is, I try to provide the reassurance that in some ways, the very fact if they had a family history, for example, was a risk factor. And so knowing this new information, we're still in the if they're cognitively unimpaired, this is a risk factor. It's not a sentence that something is going to happen or a certainty that something's going to happen. And then I really try to point to the risk reduction opportunities. And almost everyone, if you take the Lancet figure of the, 14 things, I really try to focus the discussion on what are things on this list that you feel like you have opportunities to improve, to lower your risk, and really try to take the conversation that way.
We'll have a link to the Lancet report on the risk reduction. So it's a great thing to bring up. I wonder, okay, we're not screening using biomarkers. Barak, are you telling people to screen for cognitive impairment? MCI?
Yeah. So the work that we do with the Cognition Primary Care Program tries to be sort of open-minded and agnostic about the question of screening, in that I don't think that screening is wrong. It's not necessarily something that I think like we have great evidence that it should be very strongly encouraged.
You're like the USPST. I always add letters to that USPSTF.
Yeah.
I added a letter. Not
what
enough information.
Yes. And when I experience a clinic that is doing screening, like I say, good job. I think that you are probably doing good by doing that screening. But I really focus on the concept that, the giant bottleneck that we face is not sort of whether we should be screening or not, but, when a concern arises, whether it's from an abnormal screening test or it's somebody saying that they are sort of concerned about their cognition, the real kind of important step to take is to help primary care to do a cognitive evaluation that is like past the screening step. So to me, I'm like, I think screening is good and it's fine, and places that are doing it are good. But I think that we're wasting a lot of time sort of arguing about whether or not we should be screening, because it's like it's fine, but it's also a little bit fraught and there is some uncertainty. And so to me, I think this whether or not to screen isn't the question. It's how can we help people for which there is a concern.
Halima, you look like you're thinking about that.
Yeah, no, I think I actually totally agree. I think I am usually more in favor of that kind of proactive case finding, right? It's like the semantics of screening versus case finding. So I've actually always sort of agreed with, I think, some of what the expert task force have put together for like the annual wellness visit, which isn't, you should mini cog everybody, but it's you should ask. And if there's a concern, do a mini cog, or if you can't confirm it with someone else. But I do think I mean, I generally do when I talk to primary care is just start asking about memory and start asking about brain health the way we ask about all these other symptoms and conditions that we feel more comfortable about, so that we can kind of more proactively detect, or at least, kind of give people permission to bring up a complaint that they may otherwise be nervous or anxious or unsure about whether they should bring it up.
Because screening is good, and like there it is. Like, I think that screening is like important and a reasonable thing to do, but it's just not sufficient. That there are plenty of people who have mild cognitive impairment who score fine on a mini-cog. There's no such thing as a 2-minute screener that has such good sensitivity for MCI that you kind of like screen and you're done.
So if somebody does have complaints, what are you training your primary care providers to do? What's the assessment?
Yeah, so first ask more about what the concern is, and making sure that it's not just the kinds of things that freak people out that are normal aging. But then if there is like a real concern, then it really is bring somebody back for a dedicated visit to do a cognitive evaluation, where you're not going to talk about their knee pain and you're not going to refill their diabetes medicines, but you're just going to do a cognitive evaluation, and you're going to try really hard to get a family member or a close friend to come to that visit with them. And then you're going to do 3 components for the evaluation, which is going to be a review for addressable causes, interview with the patient and the family member, and then some kind of a cognitive diagnostic aid test.
Like a biomarker?
No, like something like a MOCA or equivalent.
How do you feel about that, Heather?
So I love the term case finding. So I am a big proponent of proactive case finding, and I think I was hearing Barak say the same thing, that you're almost more worried about somebody would just screen and then decide, oh, this person's fine because they scored, well on the 6-item screener, and we all know that we'll miss a lot of cases. So I also worry that we miss a lot of cases that are out there. And the reason that I do think that proactive case finding and cognitive assessment is now important, this will probably pivot us into the treatment fair, but we have treatments now that are available for people with cognitive symptoms. And if we have people with cognitive symptoms, I'm of the opinion that they deserve the discussion and the consideration of whether they want to go forward with these treatments. And I say that knowing that more people that I talk to about these treatments choose not to take them than choose to take them. But we have treatments now for people with cognitive deficits who are then found to be amyloid positive. And I feel like it's increasingly important that we don't miss somebody who might be a person that would benefit.
So the treatments you're talking about is the amyloid antibodies, so lecanemab and donanemab. How do you talk to patients about what we know or what we don't know about the effectiveness and risks about them?
Yeah, so and it differs. And I will say in my practice, I work in an interdisciplinary memory clinic. We have psychiatrists, neurologists, and geriatricians, and nurse practitioners and PAs that all sit together in the same workroom. We all follow the same. We don't prescribe the drugs unless it's in accordance with the use recommendations. So we don't kind of go completely into cowboy land with them. But even within that, like all things in medicine, you can be prescribing within the use recommendations and still real differences. And so I will say, again, because I think it's important that we show our cards on the table, if you line up like all 8 of us, there's a spectrum of I always say that I always kind of think of the scales with risk on one side and benefit on the other. For me, in average people, the average population, the risk benefit of these drugs sits pretty close to 1. And then sometimes particular patient factors or priorities and goals shift it a little bit, from more towards risk or more towards benefit. I am a person that, for me, if it were me thinking about taking them for myself, I'm not going to take a medication unless the risk-benefit ratio favors benefit pretty significantly. So probably it's
especially a medication that you have to go in every other week or once a month. You get MRIs, you get the whole...
For me, all that's on the risk side. Like on the risk, sacrifice, burden, cost, everything bad is on one side and everything potentially good's on the other side. I know that of my colleagues who know the literature well and I trust, and if they were making the same decision for themselves, knowing everything that I know, they'd be more likely to take the drug in the same scenario as me being less likely to take it. And that just, I think, emphasizes how much personal priorities and goals and preferences weigh on both sides of those scales too. So I would say that these are the hardest conversations that I've ever had in my time as a geriatrician. And we all know that we have a lot of hard conversations.
Wow. Do you think these conversations should be discussed in primary care, like brought up?
Yeah. So, I mean, it's the number one question that, we get when we do our training for primary care is, well, what about the drugs? And I think that it's really important for primary care to be aware of the drugs, to be aware of how to talk about them. And I, will say that, there are drugs that are, have been shown to be, better than placebo. And that, they're not a lot better than placebo, but they're better than placebo. And the potential for somebody to be eligible for them is like an important thing for primary care to be aware of and to feel comfortable in talking about. But I think it's not necessarily the top priority. Like the very top priority after a diagnosis of mild cognitive impairment is made is to really, work through the easily addressable factors that can be sort of like, it's what primary care doctors do all the time. And so I think that is, that is the focus and the key. But just like Heather said, there's going to be some people who are like, I want to talk to a specialist right away about one of these drugs. And I think that it is a disservice for primary care to kind of get in the way or use what my own personal sort of preference would be if I was in that situation, to in any way kind of shift somebody away from getting that possible evaluation.
Yeah, I think about that a lot. Would I take these drugs if I had MCI or mild dementia and I fit the guidance? And it's a strong. I probably wouldn't just. It would be just on the amount of medical stuff. Like I don't even like taking like a blood pressure pill every day. So that probably would influence how I think about it. Halima,
Eric,
you?
One thing I was going to say that's interesting there is I've had a few patients who they miss going to the infusion center now that they have completed treatment. Like they actually enjoy the social interactions,
it's like the
nurses.
unit.
Yeah. So, while a lot of us look at infusion as a burden, and I think the other hard part, right, is for me right now, it's like, I have so much going on. But hey, if I'm 70, I'm retired, like there's a lot of people like, oh, that's no trouble. I had a patient recently, they were deciding which infusion center based on, are there better cafes and restaurants near that site? So, some of that burden, I think we think, oh, the MRIs are hard, and people are like, that's no problem. But these are long conversations. Like even in memory clinics, sometimes I'm like, I don't have enough time. I need to do a separate video visit first to discuss risks and benefits, talk it through, do it justice, where, I don't expect primary care to have that time. And to be honest, I don't know that even community neurologists who have 15, 20-minute visits can actually do justice to that conversation to really make sure patients understand risks, benefits, that it's not a cure. But there's definitely cases. I mean, I will say now I might lean towards, if I didn't have risk factors, to now that we're seeing that in clinical practice, we're not seeing sort of increased adverse events from the clinical trials, that, in the right setting, in the right space, I would be open to it. But it's still, I mean, I have a lot of patients where I would sort of say, I would love to be able to give you a recommendation, but I don't have a strong one way or the other. There are some people where you can go strongly, against, but I think for other folks, it's trickier.
And for me, it's kind of like one of the superpowers of primary care. Like the relationship that you develop with somebody over years, and you have experience of how they have faced sort of like complex decisions where they're like, oh, geez, I don't want to take a statin. Like, why are you recommending a statin? Versus the person is like, can you check my, lipoprotein little a, because I really want to like know what my risk is. Like you kind of like, you understand and develop rapport with your patient over time. And that really can help in a situation like this where you diagnose somebody with MCI and you sort of like have a sense of like how to kind of like frame the conversation with them. And you have like a hunch going into the conversation, like, oh, this is somebody who is definitely going to want to see a specialist right away, versus this is somebody who is like never going to want like testing that you're not absolutely certain is going to have like big giant benefit.
I have heard, and this gets us into biomarkers, that some neurologists want the primary care doctor to order the biomarker first to determine if they should see the patient.
Yes, we've heard that. Maybe on this show as well. Mm-hmm.
Barak, do you ever order biomarkers, or do you ever teach primary care providers to order biomarkers?
Yeah. So, I mean, and so this is, so the number one question I get is like, what about these new drugs? And then the number two question that I get is, what about these biomarker tests? And for me, it's so important to see like the big giant picture, like what does this biomarker tell you? And, so like the number one is like, never primary care should you be ordering a biomarker unless you have already diagnosed somebody with MCI or dementia. Like I think that it's a big giant sort of trap to fall into is if you sort of like include it with your like initial workup of like TSH, B12 and biomarker is like, like a terrible way to work somebody up for cognitive impairment, because you might very well end up sort of like with the great news that somebody does not have cognitive impairment, but then you're sort of left with this biomarker result.
Heather, Halima, I see you nodding yes. You're in agreement.
Yeah. So, wait till in primary care, for sure, wait till after a diagnosis of MCI or dementia has been made. And then the question of sort of what role does a blood-based biomarker have in the primary care setting? And to me, like, because you have to sort of step back and say, what's that biomarker going to tell you? It's going to tell you that cognitive impairment is due to Alzheimer's disease. And then you have to ask the question, like, what impact is that diagnosis of MCI due to Alzheimer's disease going to have on that patient's care? And if somebody is the kind of person who, like, yes, I would absolutely want a monoclonal antibody treatment, and you'd feel confident that you're going to be able to get them to see a specialist within, 2 to 4 weeks to get that treatment started, then I could see that being a situation where primary care would order a blood-based biomarker as a way of kind of fast-tracking somebody into monoclonal antibody treatment. But in a setting which is what most primary care providers are in, where even if I get that blood-based biomarker, it's still going to take months to get in to see the specialist. And in those months, it's going to be up to me to interpret what this result means for the patient. Then I don't want to be in that position as a primary care doctor.
And for the patient, I think, for me, it will make my life easier as the receiving specialist if I already have that result at the time that they come in. But I like to think that I'd want the patient experience to come before my convenience there. And I do worry about patients that will say it took 5, 6, 7 months to get in to this clinic.
Yeah.
And I've been sitting on pins and needles because I was told I had this positive, that someone did appropriately diagnose me with mild cognitive impairment. Then they told me that this test was positive. Sometimes it's an amyloid PET, sometimes it's a blood test. And now I have to wait 6 months to see someone, and everything I'm reading, because I'm obsessively reading on the internet, and everything I'm reading is saying that earlier I get treated, there's a window of benefit opportunity. And I feel like that is a real challenge that we're just dealing with in the field right now.
I'm also a little like the idea that if somebody has, let's say, MCI or mild dementia and their amyloid is negative, does that mean that they don't need to see a multidisciplinary memory? Like, it's almost more like, oh, wait, we don't know why this person is having memory problems. Almost increases in my mind the need to see someone like Halima or Heather. Halima, what do you think about that?
Yeah, no, I agree. I think I generally have been, again, when I talk to primary care audiences now, saying I would probably rather order the test myself, choose what I'm ordering, be able to have a discussion about the quality of these tests and what they tell us, what we're going to do with the results before getting them. Otherwise, I have occasionally said to a primary care provider, right, if someone's really excited, if they have an appointment, order the test like 2 weeks before. Have them get it 3 weeks before so they're not sitting on it for 6 months, but then they're coming straight in. But I do think that's important, right? Because they still have cognitive impairment. And sometimes that's when now I'm thinking about, do we need more neuropsych testing? Do we need an FDG PET scan? Are we thinking about other types of dementias? What do we need to do for monitoring? But then I think what we're running into is the bottleneck of just there's not enough dementia specialists now to handle this influx. I was actually curious, Barak, too, from your perspective, is we also have some patients who just want to know they're not a candidate for treatment for some reason. And I know I order biomarkers in that case, right? They're deciding if they're going to move or something. I was just curious your thoughts on that, like if that might start to come up on the primary care side.
And I see that as like, where we might be with blood-based biomarkers in 5 years or so. I mean, I think to me, like the number one clear use case for blood-based biomarkers is establishing eligibility for monoclonal antibody therapy. And so, like no question, you've got a neurologist who can fast track them in and get them in right away. If they have an abnormal biomarker, like, yes, I will definitely order that test in primary care to kind of like ease the way to help the patient. But if somebody is like, what is the other use case for these biomarkers, which is like, just to know, I think that's sort of like tantalizing and interesting and sort of like down the road. Because I mean, I will say that as a primary care clinician, to make a diagnosis of MCI is often like, a weird kind of like gray place to be, because you're not really sure exactly what to say to somebody about their prognosis, where, we see dementia as this, generally progressive disease. There's a lot more uncertainty about what does MCI mean and, what is somebody's prognosis who is diagnosed with MCI, and whether a blood-based biomarker could be part of a helpful sort of prognostic sort of piece of information to know is interesting. But I think that will probably be part of a package of, blood-based biomarker for Alzheimer's disease and a biomarker for Lewy body disease and a biomarker for frontotemporal disease, where you're going to really be able to say, you have MCI, but we have done a really pretty thorough biomarker look for the pathophysiologic causes of neurocognitive degeneration, and we haven't found them. That's like, you're in a low risk, better place. And so I could see us being in a place like that 5 years from now, but I don't know that we're there now.
Can I bring up a question around that is about the sort of getting there with the evidence, and that is comorbidities. So I don't know, I'm curious for Barak, sort of when you're teaching people about how to potentially use and interpret the biomarkers, the presence of comorbidities obviously affects the accuracy, particularly of the blood-based biomarkers.
Kidney disease, cardiovascular disease, obesity.
Certain medications can affect amyloid levels, things depending on what biomarker is being ordered, different comorbidities. And then there's the specter of comorbid pathologies in the brain. So if I might get this result and it says amyloid's present or it's not, but it is, just as you're saying, it doesn't also tell me what other things might be in the brain. And we know from autopsy that oftentimes these things co-occur. We think it probably affects the prognostic utility of knowing about amyloid if somebody also has heavy vascular burden or also has Lewy body disease. What are thoughts right now about how to sort of manage all that in a heterogeneous, real-world primary care population?
So I tell primary care, don't do it. It's just so complicated and confusing, and it really.
That's why you're saying 5 years from now.
That's right. It is currently outside the scope of primary care. Like, I think the best analogy that I sort of use that really kind of resonates with a lot of primary care providers is, if I diagnose somebody with, what looks like a myeloproliferative disorder, where, their CBC, their diff is abnormal, and I'm sort of really worried that they have like some kind of lymphoma, but I don't know exactly what kind. I'm going to get them to see a hematologist oncologist within 2 to 3 weeks. And that hematologist oncologist is going to say, in preparation for their visit, could you get flow cytometry for me? Because then if I see them for the first time and I have that data in front of me, it's really going to sort of like speed along my ability to sort of like, diagnose and get them into treatment. And I'm like, sure, because I know that they're going to be able to be seen in 2 to 3 weeks, and I'm not going to be on the hook for interpreting and counseling them about that result. And so to me, that's like the great analogy for blood-based biomarkers, where if I feel, and I think this is what we should be sort of like skating towards as sort of a best practice, like every health system, every, cognitive neurology clinic should have some kind of a fast track path where if a patient has a blood-based biomarker that indicates high eligibility for anti-amyloid therapy, that patient should get seen like quickly and get started on
Can I
therapy
ask,
like
so
that. Yeah.
hypothetically in that fast track, like Heather, like in your mind, again, patient experience versus your own, like, wouldn't it be nice? If it was, wouldn't it be nice? You got options for biomarkers. You got amyloid beta ratios. You got p-tau 217, p-tau 181, neurofilament light chains. Like, what are you asking people to order? What do you order?
Yeah. So when I start with a blood-based biomarker, and I wouldn't treat somebody without, at this time, without confirmation for a positive result with a PET or lumbar puncture, but I start with p-tau 217 ratio with A beta 42. So that's the ratio that I use. And the issue is that it gives you this intermediate values in the middle. So about 10 to 20% of the people that we order that in have to then go on to the,
Why are we using ratios of two different
Yeah.
tau and amyloid?
Yeah, so it does a couple of things. One thing is it just appears to be a better performance characteristics for how well it predicts the presence of brain amyloid by gold standard tests. So by PET or the area under the curve, if you will, is better with that ratio. So it's just performance characteristics are better. It also, in my mind, it appears to guard against some of those comorbidity issues that we run into. So the ratio, for example, looks less sensitive to kidney impairment. And so that's why I choose the ratio.
Yeah.
I serve on a panel that is doing systematic reviews and then clinical practice guidelines based on them for how to use the blood-based biomarkers, and we'll continue to update them. But p-tau 217, and particularly the p-tau 217 ratios, either percent of p-tau 217 out of all the phosphorylated tau or with the ratio of A beta 42 are some of the top performers so far.
I also love the altsdiagnostichub.org website. Like it has, I didn't realize how many biomarkers out there.
Yeah, that's, and that's actually an interesting
huge
thing.
Sensitivity and specificity differences.
So huge difference. And I would say that's the biggest myth of when other providers come to me, they'll say, wow, I heard that there's a new blood test for Alzheimer's. And it's like, dude, there are lots of blood tests for Alzheimer's. There's not one blood test for Alzheimer's. So, and they vary a lot. Yeah. So it is really important for people to know what they're ordering.
Halima, what do you order?
I was going to say, what I was going to add to that conversation is what can I order in my EMR? Right. So like people are like, oh, this is FDA approved. I was like, well, I can't order it yet, for my patients. But in general, we end up doing actually sort of similar p-tau 217 and then the A beta 42 to 40 ratio. But because it's what we can order, ours is linked to LabCorp. So there's like the ATN profile, which the way it gets interpreted when it says that someone's amyloid negative is actually incorrect. Because they might be positive. That one's got p-tau 181. But then we end up kind of pulling the p-tau 217 separately, pulling in the A beta 42 to 40 ratio. The neurofilament light chain, I feel like for our Alzheimer's patients, unless they're advanced, is almost never positive. And so I've only really seen that positive if someone, again, has more advanced Alzheimer's, or sometimes that drives me down that FTD or thinking about other causes path.
Okay, lightning round question. I know you're running out of time, but the question came up earlier from Heather is what would things look different if some of these primary prevention studies, so studies of amyloid antibodies in people with normal cognition, showed a benefit? So I think there's going to be a report out in July or something on lecanemab's primary prevention. There's a donanemab study going on. Interestingly, they're not looking at like conversion to mild MCI or mild dementia, right? Because the time from amyloid positivity to symptoms could be 10 or 20 years. They're looking at very small changes in correct me if I'm wrong, Heather, very sensitive cognitive tests to see, are we seeing any change in that? Does that sound right, Heather, as far as the outcomes from these trials?
Yes. Yeah, there are lots of things in the pipeline.
Yeah. I wonder, Heather, I'm going to go to you because you said, my risk benefit, if I had MCI or mild dementia. I guess my question to you, let's say it's a positive study, that there is this signal. It's probably going to be the same as, honestly, like lecanemab. You're going to see a small change, and we're just going to be arguing about clinical importance of it, because that's always how it's been with Alzheimer's drugs. Like, how would you think about whether or not to take these drugs, or how to talk to patients about these if the same thing happens here? Again, statistically significant, clinically, we're arguing, what does X amount difference on this subscale mean?
Yeah. So I will say that the drug that I'm really waiting for would be a decade away, because we would need that long of time to know for sure, is this a drug that is eventually going to make me not get MCI and dementia? If we had that. So I don't know that I would change my own personal choice that I would make based on wishy-washy clinical outcomes or clinical outcomes that I'm not sure I'm getting benefit. Because here I would have a different calculation if I were a person without symptoms and was pretty convinced that taking this drug for 18 months, even if there was some high risk to me during that 18 months and it was a bit disruptive, if I thought that 15, 20 years from now, it would make me have more older years without dementia, I would be much more likely to do it. Actually, for me, more likely to do it than doing it when I already have cognitive impairment. Because a little bit for me, the calculation is, if I have to accept something like lecanemab now, and I already have cognitive impairment, in a way, I'm making what could be some of my best time yet really difficult with having to take infusions. And for me, the anxiety, like I would be anxious about all the ARIA and all that kind of stuff. So personally for me, the trade-off of that 18 months when I'm already cognitively impaired, and that means things are moving and that could be some of my best time left, I'd actually rather take my 18-month risky hit earlier in my life, maybe, when I feel like I have more of a runway left of really good.
That's really well said. I haven't thought about that. That is really well said. Halima, what do you think?
Yeah, well, that comment I appreciated, because I was going to say I'm hopeful that I'm young enough that I'll have that like 10-year data to see what it looks like, the long-term data. But I think it would depend. But I think I could be convinced if, right, especially I think for folks who know, for example, they have a family history, that there's something about them that sort of feels higher risk, that amyloid positivity will mean something. And then I think the other big piece too is we know that like the subcutaneous lecanemab is coming, where the risks might be the same, but the administration might be easier. But I agree with you. I think it's going to be very similar to now, where it's cloudy. There's not a right or wrong answer, and everybody sort of makes the decision.
Barak, give me a right or wrong answer here.
Yeah. So, I mean, to me, it's also hypothetical, because I think, to me, I would really want to see, like, what was the benefit and what was the risk, and so to just say that it's like a positive trial, like, leaves a lot unsaid about like how positive, I mean, I think you said it exactly right, that it's more than statistical significance. We really are going to want to look carefully at clinical significance and how does that sort of balance against potential harm. So to me, I have trouble sort of giving you a hypothetical answer without sort of
I'm going to be fascinated
on what the hypothesis is.
I think we're going to need all three of you back on, because I think we struggle with these drugs with MCI and mild dementia. If there is a positive signal with these trials, I think the struggle is just going to be so much more magnified. And the questions about clinical significance is just going to be so huge. But that's for a different time. Maybe Alex, you can take us off with, what's the song title again, Heather?
No, Harmony Hall.
Harmony Hall.
Before I sing Harmony Hall, a quick plug for my co-host who published a paper on the importance of function in Alzheimer's disease management and diagnosis in JAMA Internal Medicine this month. We'll have a link to that in the show notes. Here's a little bit of the chorus.
And the stone walls of Harmony Hall bear witness. Anybody with a worried mind could never forgive the sight of wicked snakes inside a place you thought was dignified. I don't want to live like this, but I don't want to die.
Heather, Halima, Barak, thanks for joining us on this podcast.
Thank you.
Yeah,
and thank you, everybody, for your continued support. We'd also like to do a brief shout out to those listeners who've donated more than $250, including
Kate Mesrich, Jen Hopping, S. Ashad Abid, Michael Bordowski, Harry Hahn, Carol Heyman, Gretchen Schwarzy, Sharon Bragman, Elizabeth Chung, Paul Amatelli, Brian Cassell, Victoria Braun, Susan and John McFadden, Christopher Heck, Emise Simoji, Matt Schuster, Carrie Hagan, Lloyd Woolstat, Carrie Levy, Mamie Fetzer, Ron Sabar, Stephanie Gabatuller, Patrick Lally, Richard Lewis, Margaret Leung, Cindy Harris in honor of Emily Guillot, April Sear, Anna Nayak, Xinyi Wang, Sudha Chandrasekhar, Michelle Reisner, Asher Edwards, Susan Nelson, Rebecca Goldstein, Rochelle Bernacki, Carol Dietrich, Mark Andrews Wren, Elizabeth Cobbs, Amy Rack, and Meg Walhagen.
Your support keeps the microphones running, so thank you very much.